welcome back. Welcome back. That was a great poster session for all of you who are presenting. Great job. I'm Christopher Hernandez from the Department of Orthopedic Surgery and Bioengineering and Therapeutic Sciences. And I'm here to tell you all about the oral presentations this afternoon. We have a great lineup. Each student is presenting for only 7 minutes, and then they have 1 minute after. So maybe one question. So try and jump your hand up so we can get that one question in for the presenter. And with that, we'll go on to the first presenter. This is Anson Lai, and his presentation is entitled Longitudinal Structural Equation Modeling. Children Caries Show Important Multi-Level Sociocultural Effects. Thanks.
Thank you, guys. Whoa. Thank you, guys. First of all, welcome back. About a week ago, Roger told me that I'm first to present after lunchtime, so I'm battling food coma today with you guys. But I wanted to talk to you about modeling children's caries. And before I begin, I wanted to ask everyone a quick question. The question is, do you ever look at someone and wonder, what is going on inside their head? Well, I know what's inside Riley's head. First, there's joy. And as we all know, joy brings happiness to Riley. And if you would have wanted to find out the correlation between joy and Riley, what they teach us in school to do is they say, okay, let's put joy on the x-axis and let's put Riley on the y-axis. And then you find some data points and then you draw a line through it and boom, we know that increases in joy increases Riley's emotional state. But as we all know, it's never that simple. That's because Riley doesn't just feel joy. She feels sadness, she feels anger, she feels disgust, and she feels fear. And all of these emotions come together to form Riley's emotional state. But to make things even more complicated, these emotions, just like in the movie Inside Out, also interact with each other. So now it's a lot more complicated than before. As it turns out, oral health can be modeled in a very similar way. Things like culture, physical environment, socioeconomic status, social support, and also health behaviors, these factors don't just impact oral health, but they also affect each other. And that gives us a really challenging task because the question now is, how do we model these interactions? We can't just draw the same graph we drew earlier. That's not going to work. So what we do is something we call structural equation modeling, or SEM. And this technique allows us to essentially determine the multi-level risk factors that directly affect DFS and also indirectly affect children's caries. And this will bring me to my hypothesis. The hypothesis being that a good fitting SEM model, structural equation model, will show that child, family, and community risk factors significantly affect the number of decayed or failed surfaces in primary teeth. I'm going to break it down real quick. So a good fitting model is a model that's going to accurately represent the real world situation. So that's a good fitting model because that's the keyhole question in a PAT exam. And then we would look at child, family, community risk factors. Looking at 5 risk factors usually isn't enough. So we're going to look at 54 risk factors that belong from the child, family, and community levels. In addition, our outcome, the thing we're going to measure, is the number of decayed or failed surfaces, which is DFS. As you can see here, we have a MO prep on number 30, so that's a DFS value of 2. And an increased value means that the kids has a lot of caries, a lot of fillings, which isn't ideal. And the lower value is good because that reflects the idea that the children has good oral health. And we're only going to look at primary teeth. So the hypothesis as a whole shows that we're going to try to create an accurate model that accurately defines all the risk factors associated with children's caries. And we're going to measure this by seeing how many decayed or failed surfaces we have in children's teeth. Now, to test this hypothesis, what we did was we collected data from 3 past studies in San Francisco, where Riley also lives, and also San Ysidro. And all together now, we have 1,522 children aged 1 through 7. And we also collected 54 risk factors on child, family, and community levels. So in a way, we have a wealth of data at this point. The next thing we need to do is multiple imputation. So a lot of times, if you're working with large data files, what can happen is that you can have missing data. For example, here I'm missing this data like here. So in order to not throw all this data away, what we can do is something we call multiple imputation. As you can see, I'm running 5 iterations of multiple imputation, and I'm going to ask the computer each time to predict what kind of values belong in the missing value part. So the computer runs this algorithm, and it determines these are the imputed data. We go ahead and take the average to find out what the average data is. And most of the time, this is pretty accurate, but the hope is that this allows us to fill in any missing data we have in our data set. And finally, we perform structural equation modeling, which once again, simultaneously allows us to model the direct and indirect effects of each risk factor. As you can see here, we have 54 variables, which is a lot, and you can barely see it. So we went ahead and Dr. Gansky and I said, okay, let's look at a few important ones. So we looked at 16 key variables, and then I'm gonna go over what we found here. The important part of this slide is just that we eventually tested this model. We determined that this model was good fitting because we saw that 2 out of 3 standard measures of model fit showed that our model was accurate in representing the real-world conditions. But the important conclusions come from this slide, which shows that, for example, if the mother in our study was a student, perhaps due to the stress of balancing education and parenting, we noticed that these mothers came from families where there were fewer oral health promoting behaviors, which then lead to increased DFS. Conversely, if the mother stays at home, we noticed that there were more oral health promoting behaviors, which then decreased DFS. And this highlights the potential need for support systems to help student mothers inside San Francisco or California to essentially allow them to alleviate some of their stress at home and spend more time with their kids in order to promote their oral health and decrease DFS. But the main take-home message I want to say today is that we discovered that community risk factors shape family dynamics, leading to increased number of decayed or failed surfaces in children's primary teeth over time. Okay, let's take a look at this model. We can see that there's correlation between community and oral health, but the stronger correlation comes from the fact that community impacts family, which then impacts the child, which then impacts children's oral health. And what this tells us is that family dynamics serve as the crucial link between community and oral health as well. And what this implies is that if you're going to design some kind of intervention, dental education, oral health programs, community outreach, it's important that families are first empowered with the knowledge and gain access to these resources in order to foster a better environment for children at home. And that's the main take-home message I want to give you guys. And seeing as we have some time, I want to go over some acknowledgements today. So I wanted to share a personal story. About a year ago, I was sitting in this crowd and I didn't know what I wanted to do after graduation. I was pretty lost and I was unmotivated because I had no real goal in my head. And just like how Riley eventually grew up to gain 3 new emotions, I was lucky enough to meet 3 people who have really shaped my journey here in dentistry. And they really gave me courage to take on this project that I originally didn't want to do. And it opened me up to taking on new challenges in dentistry. And that's really opened up my world here at UCSF. And I feel so much happier now. And I wanted to basically say that if you're sitting in the crowd today and you feel like you don't know what you want to do yet, that's okay. But at least take on a challenge because you never know where that might lead you in life. With that said, I'd like to open up to any questions. This is a picture of me explaining inside out to Dr. Gansky. So that's really cute. Thank you, guys.
All right, we got time for a question. Any questions from the audience? I have one. What are the relative weight? How do you figure out the relative weights when you're making these of all the different factors you have in your model?
So the question was, how do I figure out the relative weights of all these factors we have in our model? And for structural equation modeling, the first thing we did was we took all these variables and we essentially scaled them from 0 to 1 so they would be more equal in terms of the actual model itself. But if we look at the actual model, we have correlations here. And obviously a larger number shows a larger correlation, but the most important part is to see if numbers are positive or negative. A positive means that these risk factors increase DFS. A negative number means that it's protective against it. So I wouldn't really put too much emphasis on the weights, but more about whether or not positive values or negative values. Thank you for your question.
Thank you.
Thank you.
Wonderful. All right. Our next speaker is Justin Chow.
Thank you for the introduction. Hello, everyone. My name is Justin Chow. I'm a 3rd-year dental student. Let's get started. I want you all to imagine an invisible web of fibers holding your body together. That's collagen, and it's the backbone of our connective tissues, forming structures like the periodontal ligament, which support our teeth. Now, collagen undergoes a very unique self-assembly process. It starts with collagen molecules, which organize around each other to eventually form collagen fibers. And this delicate process can be manipulated to dramatically affect tissue development. For example, it's possible to mineralize collagen fibers to induce bone formation. And this can be done through the use of biocompatible polymers, such as polyaspartic acid and polyacrylic acid. And these polymers are able to chelate ions of calcium and phosphate into a stabilized nanodroplet structure. These nanodroplets are then drawn up into collagen fibers to unload the ions of calcium phosphate and induce biomineralization. This process is driven by the electrostatic interactions between the polymers in the nanodroplet and the collagen fibers, and it's called high concentration polymer-induced lipid precursors, or HC-PILPs for short. And recently, our group evaluated the effects of HC-PILP in orthodontic relapse. And orthodontic relapse is the remodeling of the periodontal ligament after orthodontic force has been removed to shift teeth back to their original positions after orthodontic treatment. It's one of the biggest challenges in orthodontics, and we hypothesized that a local PDL injection of HC-PILP could minimize orthodontic relapse. And here's the experimental design. We induced orthodontic tooth movement for 28 days. And on day 28, we removed the orthodontic force, and we delivered a local PDL injection of either phosphate buffered saline as a control, the polymers of polyacrylic acid and polyaspartic acid alone in water. And these are just the polymers in the nanodroplet, just without the ions. And from here on out, I'll be calling this group the polymers and the HC-PILP. And as we monitored relapse, we saw that on day 4 of relapse, the group treated with the HC-PILP and the polymers displayed significantly reduced orthodontic relapse compared to the group treated with the PBS control, which displayed almost 45% of relapse of tooth movement. And I want you to focus on the green bar here and notice that this trend holds true for HC-PILP all the way out to day 24. To further understand this, look at the we took histological sections of the periodontal ligament during orthodontic relapse, and we stained for collagen maturity and orientation. And the white dashed lines indicate tooth and bone borders, with the section in between being the periodontal ligament. And unsurprisingly, right after orthodontic tooth movement, we see a large lack of collagen fibers in the periodontal ligament due to the orthodontic compressive forces. And during orthodontic relapse on day 12, in our group treated with the PBS control, we see a large recovery of collagen content. In our group treated with the polymers, we see a similar recovery of collagen content. However, the orientation is slightly altered. And in our group treated with the HC-PILP, there's a stark reduction of collagen fibers, indicating that HC-PILP is impairing the ability of the PDL to remodel. And this also led me to my main research question, which was to understand why HC-PILP was having such a significant effect on reducing collagen formation. I hypothesized that this could be due to 2 main possibilities. One, HC-PILP could be having a direct effect on collagen by preventing collagen molecules from forming collagen fibers. Or 2, HC-PILP could be having an effect on fibroblast cells and preventing them from producing collagen. So to test the first part of this hypothesis, I worked with a PhD student to run a collagen turbidity assay, which analyzes the ability of collagen to self-assemble and form collagen fibers. And I saw that when collagen was incubated with high concentrations of either HC-PILP or the polymers, collagen formation was significantly decreased. Interestingly, when I incubated collagen with low concentrations of these same treatment groups, we saw that collagen formation was slightly slowed in the beginning, but ultimately collagen formation was elevated. To assess this further, we took a look at the protein secondary structure of the collagen incubated in these same treatment conditions. And we saw that when we focused on the IMID1 peak region, there were alterations occurring in the high concentration groups in dark purple and in dark blue. Specifically in the non-treated collagen, as well as in the low concentration groups, the IMID1 peak wave number was consistent at 1639. However, in our high concentration groups, a left shift occurred to 1647 and 1658, respectively, for high concentration HC-PILP and high concentration polymers, indicating that the collagen molecular bonds are weakening, potentially due to new bonds forming between the collagen and the HC-PILP and the polymers. And these alterations that we're seeing in vivo are consistent with these alterations that we're seeing in vitro with collagen structure being disrupted is consistent with our in vivo findings that the HC-PILP and the polymers are affecting collagen formation. To test the second part of my hypothesis, I analyzed fibroblast behavior in the presence of HC-PILP, and I saw that fibroblasts incubated with high concentrations of HC-PILP displayed significantly reduced fibroblast viability compared to the non-treated fibroblast control, while low concentration HC-PILP did not have an effect on fibroblast viability. I saw similar results for the polymer treatment group, where a high concentration reduced viability and a low concentration did not affect viability. And given our previous data showing the interactions between collagen and the HC-PILP and the polymers, we suspected that this reduction in viability could be due to disruptions in the extracellular matrix of the fibroblast cells. So we analyzed the fibroblasts with immunofluorescence microscopy. And here we see normal fibroblast cells that are not treated, displaying normal cell morphology. When we incubated the fibroblasts with high concentrations of either HC-PILP or the polymers, we see that cell spreading was significantly diminished, indicating a potential disruption in the extracellular matrix. Now, consistent with our viability data, when we incubated the fibroblasts with low concentrations of HC-PILP or the polymers, we saw that cell morphology was not significantly altered, suggesting that the effects of HT POP on the polymers are dose-dependent and potentially tunable. Lastly, I observed that HT POP upregulates COL3 gene expression and downregulates COL1 gene expression, indicating a shift in the type 3 to type 1 collagen secretion ratio in fibroblast cells. And this is really interesting because the periodontal ligament derives its strength from type 1 collagen. However, other studies have reported that during orthodontic tooth movement, the type 3 collagen content in the PDL is increased. And as the PDL remodels during orthodontic relapse, the type 3 collagen is eventually replaced by type 1 collagen until normal ratios of type 1 collagen to type 3 collagen are achieved again. Therefore, it's possible that this induced gene expression profile of increased COL3 compared to COL1 may contribute to the slowed periodontal ligament remodeling that we saw in vivo at the very beginning. And taken together, these findings give us a fresh perspective on the POP biomaterial. Previously, POP has been examined in the context of biomineralization. However, the work in this study shows that HT POP is capable of modulating collagen formation as well as fibroblast behavior, with potential applications in affecting soft tissue development. And I'd like to thank the Desai Lab and the Capella Lab for all their help. I'd like to thank Darnell Kyler for his amazing mentorship throughout my research experience here at UCSF. I'd like to thank Dr. Tamara Allison for her guidance and key insights throughout my project, and also Dr. Brands and Dr. Roger Mraz for supporting me throughout the D2 Fellowship project. Thank you.
Thank you very much. We got time for one question. Right here.
Thank you.
POP has a does it affect inflammatory responses or have a, is it anti-inflammatory? Just thinking about all your collagen changes, and that's usually associated with scar formation.
Yeah, so we did run a test on seeing if there was an increase in inflammatory cells after HT POP administration, and there was no significant difference there. But however, there's that finding that HT POP is decreasing the viability of fibroblast cells. So that's something that we want to explore more, like whether that's apoptotic driven or there's some other cell signaling involved, or if maybe the HT POP is being taken up by the fibroblasts. In terms of like systemic inflammation in the periodontal ligament in the rat model, that's not something that we saw, but we're trying to explore more about the effects on decreasing fibroblast viability. Thank you.
Thank you. Our next talk is by, there we go, Elizabeth Moreno Galvez. Discovering the role of P75 NTR in temporomandibular joint cartilage formation using conditional knockout mice.
Hello, everyone. My name is Elizabeth. I'm a third-year dental student. My mentor was Dr. Hong, and I'm very excited to talk to you guys about my project today, which is discovering the role of P75 NTR in temporal-mandibular joint cartilage formation using conditional knockout mice. So, introduction. As we have a lot of dentists in the room, I'm sure a lot of us are aware about the significance of the TMJ and how it's essential for everyday activities such as eating, talking, and swallowing. But unfortunately, we can run into some potential issues with the TMJ, one of those being temporal-mandibular disorders. Examples of these disorders are disc dislocation, muscle disorders, luxation, synovitis, arthralgia, and that's just to name a few. And that's a picture of me suffering from TMD right there. So the role of our lab is to try to better understand TMJ pathogenesis in order to hopefully develop some new therapeutic strategies for people suffering from temporal-mandibular disorders. So I just want to go over some quick TMJ anatomy. As you can see on the board, there are two pictures here. On the left, we see the condyle and the disc, as well as the fossa where the condyle articulates to. And the blue there, the P, represents the periosteum. So we see that on the articulating surfaces of the condyle as well as the fossa. The purple represents the fiber cartilage, and that composes the disc, as well as the areas right underneath the articulating surfaces. On the right, we have a more zoomed in picture of the condyle, and we see that top layer is the periosteum, as I mentioned to you guys on the left. On the right, we see the fiber cartilage layer, which is a little bit deeper in the condyle. And we also see an overall trend in which newer cells are more towards the outside of the condyle. And as they're growing older, they're being pushed more towards the inside. So now I want to introduce our gene of interest, which is P75 NTR. P75 NTR is very known to be a nerve growth factor receptor and very known to be important for the development and the survival of the neuronal network. And that can be shown by the figure on the right here. But there's actually newer evidence that's actually brought upon by some lab mates, Byron Zhao and Eric Yin, that presented at previous RCEDs that show that it could also be very important for chondrogenesis and osteogenesis. So the lab has done a few studies with P75NTR, one of those being a global knockout study and mesenchyme tissue-specific knockout study of P75NTR that show that it's important for the overall development of TMJ, but also bone development. And this leads us to wonder, could we uncover a more specific role of P75NTR? So this brings us to the goal of my project, which is to identify the role of P75NTR in TMJ cartilage homeostasis by establishing chondrocyte-specific deletion in mice. So the first method that we will be utilizing is chondrocyte-specific deletion of P75NTR. So in order to achieve that, we utilize the aggregate P75 flux system in mice. So as you can see here, we have aggrecan, and aggrecan is a cartilage-specific proteoglycan core protein that is expressed by chondrocytes. And here we have our aggrecan promoter in the orange, and then we have the Kruger recombinase protein as well as our estrogen receptor. And downstream, we have our gene of interest, P75NTR, and you can see that it is contained within two LOXP sites there, which are the teal little flags there. So for this system, Cree is actually able to be activated and recognize these LOXP sites and splice out our gene of interest from the mice. And again, this is set up so that Cree expression is under the aggregan promoter, meaning it's exclusive to chondrocytes. The second method that we'll be utilizing is time-specific deletion of P75NTR. So as I mentioned to you guys earlier, the Cree recombinase protein is expressed with the estrogen receptor. And the cool thing about this system is that tamoxifen is able to identify and bind to the estrogen receptor. So the sequence is as follows. We inject mice with tamoxifen. Tamoxifen is able to identify and bind to the estrogen receptor. This subsequently activates the Cree recombinase protein. And now we're able to identify the LOXP sites and splice out our gene of interest from the mice. And for my project, we injected these mice at 2 weeks old, and that's just based off of all of the literature we read and looking at all of their success rates. So moving on to our results. I also want to mention that for the control mice, we injected them with corn oil instead of tamoxifen. We injected them at 2 weeks old, and then we harvested them at 6 weeks old. So once they were harvested, we isolated TMJ, we decalcified it, paraffinized it, sectioned it, and then stained with 3 different stains, which was H&E, Alcium blue, and Safranin O. For H&E, we performed a few measurements, which was disc thickness. PZ thickness, which represented the outer layer of the condyle representing periosteum. DZ thickness representing that deeper layer of the condyle representing fiber cartilage. And then we also measured Safranin O staining, which is shown in the blue here. So the staining shows up as red, and that represents the cartilage component, as shown here. And Alcium blue also gives us a similar representation to Safranin O, which also represents cartilage components. And on the right here, we see a summary of our measurements, all those measurements that I just mentioned to you guys. So the black represents the control mice, the black bars here, and the gray represents our knockout mice, and the stars represent the significance. So if you look at all the bars, you can see that there's a general trend in which there's a decrease of measurements in the knockout mice. And 4 out of 5 measurements were significant. Conclusions. So because of this general trend we observed, this leads us to conclude that P75NTR plays a key role in TMJ formation in a chondrocyte-specific manner. We do still hope to find an even more specific role, and that is where our next steps are aimed at. So we're more interested in the mechanism, so we're planning to utilize further histological studies as well as in vitro studies in order to achieve that. So to close off my talk, I want to express my gratitude to my mentors, which is Dr. Hong and Chiho, as well as my lab mates that helped me with my project, and Roger and Dr. Behrens for all their help through the fellowship program. And thank you so much to all of you guys, even though you guys didn't have much of a say in being here. My colleagues and I spent a lot of hard work on our project, so we really appreciate your attendance and your attention today. Thank you.
Wonderful. We got time for one question. One right down here.
Thank you. Can you explain how the global knockout study showed the importance of bone development?
Yes, I can. So I just mentioned the study, but I didn't include any figures. I was being a little greedy with my space here. But for the global knockout study, the figures mainly consisted of comparing the knockout to the control group. And the knockout group showed, when you compare the bone volume of the mandible and the condyle, they all showed a decreased bone development in that. And they also showed a decreased disc thickness. And because it is global knockout, that means that P75 NTR was knocked out in the whole body as opposed to my project, which was knocked out only in a chondrocyte specific manner.
Wonderful. Thank you again. All right. Our next speaker, I forget who's speaking. Come on up. There's two names here. Are you both speaking? Okay. Na-Yoon Kim and Sophie Zhang. Standardizing technical and soft skills of dental assisting for pre-doctoral students.
Thank you for the introduction. Hi, everyone. I'm Na-Yoon. And I'm Sophie. And this was the title of our presentation, as you mentioned. So just for some context, we're currently both third-year dental students, and based off our own clinical observations, we've noticed that students enter our school with a wide range of dental assisting knowledge, skill sets, and confidence. We have students who have come straight into dental school with no clinical training prior, while we have others who have worked years as a registered dental assistant. We found that those with previous exposure acquire skills in patient communication and interaction that are uniquely gained from experiential learning in the professional environment, meaning being in the clinic, being out in the real world. So the primary aim of our project was then to standardize the different levels of assisting that we all UCSF School of Dentistry students enter school with. So to do that, we designed a didactic presentation to supplement the Fall 2023 UCSF Assistapalooza event. Now, what is that? So this is an annual event hosted by our faculty, and it's mandatory for all first and second year dental students to be able to assist the upperclassmen at our clinic. In years past, the curriculum was more focused on the principles of four-handed dentistry, so the art of kind of passing instruments along to each other. However, there's so many other aspects of dental assisting that are important. So with our project, our didactic presentation focused more on strengthening the technical skills of dental assisting, whether that be knowing the different suction types or knowing how to take vital signs, as well as honing their soft skills, more of their proper chairside mannerisms with patients who are no longer our mannequins.
And the methods for our study included administering a survey prior to and then after giving this presentation during Assistapalooza, during which we were able to ask a variety of questions, some of which are shown here in this table. And we broke these questions down into 4 different sections. So the first one being the technical knowledge of the scope and skills of assisting, like when to use what section, how to take vitals, as well as participants' confidence in their ability to interact with patients, whether that's communicating or just through professional touch. As well as their confidence interacting with providers. Do you feel like you can support the person you're assisting? Do you feel like you can provide feedback to them? And we also included some clinical scenarios that were based on our experience in the pre-doc clinic. These were some complex situations to navigate that we noticed, and we wanted to ask how confident people felt navigating these.
So these are some example slides from our intervention, our didactic presentation. Half of you may recognize this and half of you may see it in this next year, hopefully. These are just some of the technical skills that we covered.
And these are some example slides highlighting main points surrounding the soft skills of dental assisting.
Alrighty, so moving on to our results. So these were our participant characteristics. Our sample was 105 students, which included the domestic class of 27, as well as the cohort of 2026. Interestingly enough, we had the domestic and international class for the class of 26. And these were some other parameters that we also obtained. This table shows the average number of self-reported assisting hours per self-assessed experience level. So you can see that those with no experience still had a couple hours of assisting. Perhaps they shadowed more than they had more hands-on experience, while those with advanced experience level had an average of 1685 hours, which is about equivalent to a year of full-time dental assisting during their gap year.
And so when we compared the results of the pre-survey, which is shown in orange, to the post-survey, which is shown in green, and we break it down by survey section, we're able to notice this trend where while all experience levels showed an increase in their survey scores, there's a larger increase among those who self-reported as having no to little experience, whereas that benefit is a little bit smaller for those with intermediate or advanced experience. However, you'll notice in the clinical scenarios section, the benefit seems to be relatively equal. And we think that might be because those scenarios are pretty specific to a student clinic where we are all learning. And then if you put all those categories together to represent the overall survey, you'll notice how the range of scores between those who self-reported as having no experience and those with advanced in the orange is a larger gap than what we resulted with amongst the green and the post-survey, which was kind of our goal in decreasing and standardizing that discrepancy. And you can also see that in this table with the percentage points.
So in conclusion, as we had hoped, our intervention of the didactic presentation had the greatest impact on increasing the scores of those with little to no experience, thereby helping us kind of overall decrease the gap between those with little to no experience and those with a lot of dental assisting experience.
And in terms of some implications that we hope this may have in terms of benefiting the School of Dentistry, for one, by training our students to prioritize having good chairside manners and also being attentive to patients, making sure they're comfortable through a 4-hour-long appointment. We hope that this can improve patient satisfaction, as well as clinic efficiency by training students to come prepared with a knowledge of how to best support upperclassmen. Upperclassmen have to spend less time than kind of teaching those skills because people already come in ready with those. And finally, as we do represent our school going to externship sites and beyond in our careers, we think it's important to learn about other professionals' roles on the team. So having the empathy and the appreciation for dental assistants who we may work with in the future.
Lastly, we just wanted to acknowledge our mentor, Dr. Miller, for helping us throughout the year, as well as Dr. White, who's the preclinical director, who kind of trusted us to present at the Assistapalooza event.
We also want to thank Dr. Chaffee, who is the facilitator for the ADIA ADCFP Fellowship Program, which is how we did this research. It gave us a really awesome opportunity to conduct education-based research where we identified an opportunity for improvement in the curriculum, and we were able to enact change and do something about it. So we appreciate the school's receptiveness to that.
These are our references. Thank you.
Thank you.
Wonderful. We have time for one question. Yes, right there. The mic runs behind you.
Hello, great presentation. So as a current D1 and with little assisting experience, I was wondering what are the next steps in your project to continue to improve the assisting skills at UCSF?
Yeah, so we started this project with the hope that we could continue it on and help even like decrease the discrepancy between those with little to those with a lot of experience even more. We believe that this intervention is more effective with like first and second year students kind of if you have no dental assisting experience and D2 year where you're kind of in the thick of dental assisting, kind of as a reminder. There were some other variables that we thought would be interesting to study in the future. For example, we had the international cohort. They're a special cohort that have already obtained their dental degree. So kind of looking into how, I guess, how that affects like dental assisting and how they do forward would be an interesting thing to look at as well.
Mm-hmm.
Wonderful. Thank you so much.
Thank you.
Okay, the next talk is entitled Comparative Development and Patterning of the Jaw Adductor Muscles by Sharzi Sadegh. I hope I pronounced your name correctly.
You did. Hi, everyone. My name is Sharzi Sadeghi, and I'm a third-year dental student in Dr. Schneider's lab. And today I'll be presenting my work on the comparative development and patterning of the jaw adductor muscles. So the big picture question we are trying to understand here is how the jaw muscles learn where to attach. So here you can see the temporalis and the masseter muscles are both attached to the coronoid process, which helps the jaw move around the TMJ. So different species have different muscle attachments due to these differences in jaw function and behavior. And so in order to understand these differences, we want to look more at the muscle patterning to see if we can figure out different ways to create remedies and novel clinical strategies for treating these jaw defects. So as you can see here, the quail use their beaks like a pair of forceps to pick seeds up off the ground. In contrast, the ducks use their bills like a shovel to sift through water and sediment, as you can see. So cute. Okay. So basically the duck jaw muscles facilitate leverage training and suction pump functioning for feeding, which is very similar to how the human jaw also uses its muscles for feeding. So these species-specific differences in feeding behavior are reflected in the muscles of the jaw. And so the quail and the duck and the jaw adductor muscles have different sizes, shapes, and attachment sites due to these differences. And so you can see that the quail jaw adductor muscle inserts more towards the lower midpoint of the lower jaw, whereas the duck jaw muscle inserts more proximally. And so the quail's insertion kind of is similar when you're holding a pair of forceps, you kind of want to hold it more towards the tip of the forceps. Whereas with the duck jaw insertion, it's more proximal. So that's kind of like how you would hold the handles of a wheelbarrow, kind of more towards the ends of it to kind of push that levered force. And so these 3D reconstructions show the jaw adductor muscles attaching both dorsally and distally in quail, but laterally and proximally in the duck. And so again, the big picture question that I wanted to address was, when do these differences occur and first emerge in these embryos, and what are their molecular mediators? And so the first thing I did was I wanted to quantify these differences in the jaw adductor muscles as a baseline for subsequent experiments. So I used a fluorescently labeled antibody called MF20, as you can see here, stained in pink, to stain the muscles of the jaw adductor in whole mount embryos, and generated confocal images and 3D reconstructions of them as well. And so these are the 3D renderings of the jaw muscles that I generated in Amaris, which was used for quantifications. And so these graphs do demonstrate a significant difference that chick and quail differ from the duck in jaw adductor muscle size. And I'm currently performing morphometric analyses to quantify the jaw adductor muscle shape. And so the second part of my project was to identify molecular mechanisms that pattern the jaw muscles. And so previous work in the Schneider lab showed that neural crest-derived tissues mediate muscle pattern. And so the way that the Schneider lab discovered this was by transplanting precursor cells that will make muscle connective tissues from the quail embryo into the duck, as you can see with that kind of transplanted tissue from the quail into the duck. And so normally the adductor muscle attaches laterally in the duck, like I said before, and dorsally in the quail. But as you can see here, in the quad chimera, the duck host side, which serves as an internal control, looks like a duck in terms of its lateral insertion, but the donor side looks like a quail, where the muscle moves more dorsally, even though it was transplanted were the muscle connective tissues, not the muscle itself. So basically what I'm trying to say here is that the muscle connective tissues of the quail are communicating with the duck jaw muscles to kind of create that more dorsal insertion. And so using an antibody that recognizes quail cells, but not the duck cells, shows that the muscle connective tissues are labeled, but the muscle is not. And in addition to the changing muscle pattern, the transplants also change in the gene expression as shown in that kind of white patterning in the quad chimera. And that's a key transcription factor called TCF7L2, which is expressed in the donor side in a quail-like pattern. And so this led me to test the role of TCF7L2 in patterning the jaw muscles. And so I've been altering the expression of TCF7L2 in neural crest-derived muscle connective tissues. And so I first electroporated a TCF7L2 overexpression vector in the embryo at a stage before the neural crest cells can migrate to the jaw region, which was around 8.5. Then, when I collected the embryo at stage 27, I identified those embryos that have overexpression of TCF7L2, as shown with the arrow, in the jaw muscle connective tissues. When I stained the embryos with the muscle antibody, I could see if my overexpression has altered the muscle pattern. And so on the control side over here in pink, you can see that that's the muscle that's been stained. Whereas on the overexpression side, I can see the muscle tissues that are expressing TCF7L2, which is shown in yellow around the pink, and look for those changes in the muscle pattern. And so I've also been using a dominant negative form of TCF7L2, which creates a loss of function and can also affect muscle pattern. So in conclusion, my work has shown that there are species-specific differences in jaw muscle anatomy that can be quantified in 3D. And we also found that TCF7L2 is expressed in muscle connective tissues that affects jaw muscle pattern. And overall, the knowledge that's gained from these experiments can help kind of devise those ways to treat these jaw defects in embryos. And I want to acknowledge and to thank RCED organizers for giving me the opportunity to present my work. I also wanted to thank the Schneider Lab, Dr. Daniel Chu and Dr. Ann Nguyen, and also Dr. Schneider for all of his guidance and support. And I want to acknowledge the Associate Dean of Research Student Research Fund that supported me. And I want to thank you all for your attention.
Wonderful. We have time for one question.
Yeah.
Yes.
You said that you were using morphometric analysis to analyze the shape. What kind of morphometric analyses were you using?
That's a great question. And so the morphometric analyses that I'll be using, it's called the Procrustes analysis, and that's used, it's kind of like a 3D landmark-based system that can be used to quantify shape.
Thank you.
Thank you.
Thank you so much. All right, the next talk is entitled Comprehensive Dentistry, Appointment Availability for Northern California Adults with Medicaid by Isabel Gutierrez.
Good afternoon, everyone. My name is Isabel Gutierrez, and my mentor is Dr. Akshay Govind, and I'm excited to present our project on comprehensive dentistry appointment availability for Northern California adults with Medicaid. In 2024, more than 15 million Californians were enrolled in California's Medicaid insurance program known as Medi-Cal. That is about 1/3 of the California population. Patients eligible for Medi-Cal include those that are 138% below the poverty line and/or disabled, along with other eligibility criteria. It is known that ethnic disparities in oral health care persist, and in a recent study found that about 20% of adults do report having unmet dental care needs. Low utilization of comprehensive dental care services is a crisis. It perpetuates greater usage of emergent care from patients, often yielding higher treatment costs and a reduced quality of life for these patients. California's Medicaid dental branch, known as the Medi-Cal Dental Program, does provide a website directory that these patients can use to try to find a provider and seek care. I'd like to share a little bit about my story and how it inspired this project. I grew up in what is considered a health professional shortage area in Los Angeles County, and I was the first in my family to attend and graduate from college, as well as the first in my family to attend graduate school in pursuit of a doctorate degree. It was a lack of access to care that my family experienced that really inspired me to pursue a career in dentistry. A couple years before starting dental school, one of my family members fractured a tooth, and I frantically began searching for providers using that Medi-Cal dental directory. And I called multiple providers, however, was disappointed when each of them denied accepting our insurance. Eventually, we did find a provider. However, that feeling of helplessness and desperation stayed with me and ultimately inspired this project. So in our project, we aim to really quantify that patient experience when trying to find and make an appointment with a Medi-Cal dental provider. And we do this through our specific aims, in which we evaluate the proportion of dental providers listed on the website directory that accept that Medi-Cal dental insurance. We then go on to measure the time until the next available appointment and third next available appointment. And we also determined whether there was a difference in appointment availabilities in North Bay, South Bay, East Bay, and San Francisco regions. We started at the Medi-Cal Dental Directory website, and we searched for providers listed as accepting new patients from the 9 San Francisco Bay Area counties listed here. This gave us a sample size of 425 providers. A seeker shopper with a standardized script called each of these providers up to 3 times. And if by the third call, the provider was not reached, then not reached was coded in our data. If the provider was reached, then the date contacted was recorded. Our seeker shopper is an adult new patient with Medi-Cal dental insurance seeking to establish comprehensive care. If the provider was reached, our seeker shopper went on to ask about appointment availability. If an appointment was offered, then the next available appointment, or NAA, and the third next available appointment, or TNAA, was recorded. However, if an appointment was not offered, then the reason given was recorded. So of the 425 dental providers that our seeker shopper tried to reach, 358 of them were contacted, or 84%. 220 of those providers did report accepting Medi-Cal dental insurance for an adult new patient, or 61%. We found that most of these providers were contacted on the first call, 14% on the second call, 8% on the third call, and 16% of these providers were never contacted. We found that the average next available appointment was 18 days and ranged from 0 to 201 days, with a standard deviation of 27 days and a median of 8 days. For our third next available appointment, the average was 25 days, ranged from 2 to 239 days, with a standard deviation of 29 days and a median of 14 days. In our initial analysis, we plan to compare the differences in appointment availabilities between those 9 San Francisco Bay Area counties. However, some of these counties had a very low provider count, such as Marin County that only had 2 providers and Napa County that only had 4 providers at the time. Therefore, in order to reduce the differences in sample size, we decided to compare appointment availabilities between these 4 different regions listed here. We found that these regions each had a right skewed distribution, with most appointments being less than 50 days. And we found that there was no significant difference in the third next available appointment between these 4 different regions. Of the 358 providers that were contacted, 138 did not offer an appointment to our secret shopper, with the highest reported reason being at 44% that the provider only accepts Medi-Cal dental insurance from pediatric patients. I'd also like to highlight that there was 15% of these providers listed on the Medi-Cal Dental Directory, in fact, did not accept Medi-Cal dental insurance. In conclusion, of the 425 dental providers listed as accepting new patients in the San Francisco Bay Area region, 358 were contacted within 3 calls. 220 did report accepting an adult new patient with Medi-Cal dental insurance. This is nearly a 50-50 chance that a provider listed on the directory can be contacted, as well as offer an appointment to an adult patient seeking comprehensive care. The false positive rate of the Medi-Cal directory was 15%, meaning that these providers listed on the directory, in fact, did not accept Medi-Cal dental insurance, with the most common reported reason being that, or the most common reported reason among the providers that did not offer an appointment being that they only accept this insurance from pediatric patients at 44%. And so the Medi-Cal Dental Directory may consider adding a search option where patients are able to indicate what as their adult or pediatric status in order to expedite the search process for these patients. And appointment availability is only one of many aspects that influences access to care and a patient's utilization of using dental care services. I'd like to thank the UCSF School of Dentistry Research Fellowship Program, Dr. Behrens and Roger for their support, as well as my mentor, Dr. Akshay Govind, and designing this project. And thank you to you all for listening. I'd be happy to take any questions.
Wonderful. We have time for one question in the back.
Thank you, Isabel. I did have a question. So why did you record the third next available appointment in addition to the next available appointment?
Thank you. So recent literature actually shows that the third next available appointment is a better indicator of appointment availability because it does account for any last minute cancellations that providers may have. But given that our sample size was pretty large, we didn't see that wasn't too much of an issue. But I think for smaller sample sizes, it would be a better variable to measure third next available appointment. Thank you.
One more, quick one.
Yeah. Yeah. No, for multiple reasons, but one of them being that UCSF is one of the biggest Denti-Cal providers for these patients, which I'm very proud of and very happy to be here to be serving that population. But that story I do hear pretty frequently. Yeah. Thank you.
Thank you so much. All right, the next talk is entitled EFNB1 and SHRM4 loss interacts to cause cleft palate by Karen Shamardani.
Okay. Hello, everybody. My name is Karin Shamardani. I'm fourth year DDS PhD student in Dr. Jeff Bush lab, and the title of this talk is FRMB1 and SHRM4 loss interacts to cause cleft palate. So facial abnormalities are a significant concern, and oral cleft are the most common facial abnormalities. And 50% of the cleft secondary palate are syndromic, meaning there are other abnormalities with that disease, and the rest are non-syndromic, meaning it's only isolated cleft palate. And cleft palate is a multifactorial phenotype that it can affect by multiple genes. And we don't know many of these genes and their gene interaction. And we study this in a mouse model that is a perfect model. In the top, you can see how the palatal shelf, the roof of the mouth develop in the human. And in the bottom, we can see in the mice, the palatal shelf outgrows from the maxillary prominences. It goes through this complex outgrowth and elevation, and it will fuse by 15.5, and it will make the roof of the mouth. And I'm interested in this gene called FRMB1 that is on X chromosome, and it causes a rare genetic disorder called craniopharyngionasal syndrome, that it has some phenotypes that affects the face, skull, nose. So hypotelarism, meaning the distance of the eyes are increased, craniopharyngionosis, meaning the sutures of the brain, they might be fused, they might have a cleft lip and palate, they might have an extra finger or digits, and they might have a webbing on between the fingers. This is a case that is showing the brother and sister. We can see heterozygous female are more severely affected than a hemizygous male. Our lab have been studying the heterozygous female for a long time, but this talk mainly going to be focusing on the hemizygous males. I'm going to give you guys some background in the efferent signaling. That is a very important signaling during the development, but focusing mainly on the one receptor called FRMB1 that is a key regulator of mesenchymal cell behavior and embryonic boundary formation that is highly expressed on the mesenchymal anterior part of the palatal shelf. So you can see the palatal shelf throughout the palatogenesis. FRMB1 is highly expressed on the anterior part of the palatal shelf, and the 14.5 we see both of the palatal shelf and the tongue in the bottom. And my project mainly formed from this serendipitous discovery of loss of X-linked gene called SHRM4, which is an actin binding protein, and it caused this cleft palate. So we started from collecting the skull of these mice. So this is a E18.5 inferior view of all the bones that makes the roof of the mouth. And I just want to point out in the FRMB1 hemizygous, it's unaffected, and we can see the maxilla, vomer, and the palatine bone are all aligned, versus the compound mutant, we can see the big gap and a distance that is showing the cleft palate. And this lead me to this question of that how FRMB1 and SHRM4 combined loss impacted the tissue shape and the palatal shelf. And it comes to these outcomes of the additive and synergistic. And I'm going to go through looking at the cleft palate percentage and severity and how the palatal shelf developed and how we can say it's additive or synergistic. So we can see if we look at the clefting percentage, we can see the FMB1 hemizygous is 33% and shroom hemizygous is just 10%. But when we have the compound mutant, you can see it's 100% and it's way more severely affected in the compound mutants. And we wanted to know how does this affect in the palatal shelf development in growing complex shape of palatal shelf. So we have this quantifying method of analyzing the palatal shelf in 3D. So we have collected the palatal shelf at E13.5, stain them, image them, and we have on top the anterior part of the palatal shelf and the posterior, and the palatal shelf with 13.5, they're not fused. So we have the right-hand side and the left-hand side. And I've used some other programming to make 3D surface landmarking from them. Next slide is just gonna show how are these surfaces look like in 3D. So the top is anterior, the bottom is posterior, and the silver, it was the control, and the highlighted parts in two different colors is showing these two mutants and what are their different shapes in a space. And those are the spaces that it been affected in the compound mutant. And we can say overall, the FMB1 hemizygous have decreased in a palatal shelf volume. And the way this semi-landmarking have been done by the red and the black dots are showing are being placed manually based on the biological landmarks. And we have more than 500 semi-landmarkings in the palatal shelf that we could use to do our Procasti shape ANOVA. That is a statistical test that is only looking at the shape variation, and our principal component analysis graph is showing the compound mutants, how much it is further from the control. This is very early preliminary data. We are working on getting more samples and increasing our sample size. So I thought I could convince you guys that we've developed this novel approach of using surface semi-landmarking on a confocal derivative mesh to analyze the palatal shelf morphology. And our finding was loss of FMB1 and shroom4 showed the synergistic effect in a craniofacial shape and exceeded the additive effect. And my future direction in my thesis work is working that how these two genes of FMB1 and shroom4 are interacting and why they're causing cleft palate. And with that, I wanted to thank my lab, my advisor, our collaborator, and our funding.
Thank you very much. We have time for one question. Okay. So when you look at these results, is there any utility of doing spatial analyses of looking how the cells interact, the structure interacts? Is that useful at all?
Yes, so we are looking at like how these genes are interacting. That is it like only affecting the anterior or the posterior? And this goes like beyond the analysis of just the palatal shelf. We are doing like the previous papers on like the face and the images on the skulls. So it was like the overall shape of the mouse, how it's been changed, affecting both of these genotypes.
Wonderful. Thank you. This is great. Okay, and the next talk is entitled A Rare Sarcoma in an Unusual Clinical Setting.
A very good afternoon, everybody. Yeah, I'm Nivedita Nagarajan. I'm a second-year oral medicine resident, and I'm here to present a rare sarcoma case in an unusual clinical setting, guided by Dr. Sivapriya Velupillai. So I'm very excited to share this case because it was one of the cases which challenged our initial assumptions, and it also highlighted the importance of thinking beyond obvious. So a couple of months ago, we had a patient, a 61-year-old male. He presented to our clinic, and he had a very small white bump in the tongue, which was present for approximately 6 to 7 weeks. And he did not report of any symptoms, no pain, no discomfort. But he told me something. I have something called a soda water drinking sensation, maybe medically translated to a tingling sensation. And he had no associations of any allergy, and he did not remember biting that area. The past medical history, the past surgical history was non-contributory. And the only thing was he was a former smoker like 20 years ago for 10 years, and he had occasional recreation drug usage, but he was very sure that he did not have any illicit drug usage. He was not worried, but he was curious. Like us, if we have something in the tongue for 6 weeks, obviously everybody will be curious, and he was worried what's happening. He also provided me a photograph. We love patients who give a photograph because it's a baseline. We can check how it is happening. And we took clinic visit photographs, the second and the third one. If you see, there is like a 1.5 centimeter white area in the left lateral tongue, which is not well demarcated. And if you closely watch in the third one, there is a small red linear slit-like area. This was quite confusing for us. And as oral medicine professionals, we do the differential diagnosis, and we did a flow chart, and we discussed the case. And the main 4 things which we were concentrating on was trauma, immunology, allergy, infections, and dysplasia. Dysplasia was considered because he had a history of smoking, so we have to take that into consideration. But actually, we were leaning more towards trauma because I said in the third picture, there was this linear slit. We thought that some foreign body might have lodged, or that was the area he bit, but he didn't know, and it became as a scar tissue. And then we did a biopsy. Actually, a side story, he's a very professional person. He's a dog walker. The day we told we'll do the biopsy, he said, no, I have 2 more appointments. The dogs will definitely miss me. And he said, I cannot do the biopsy today. But he came back. We pressurized him, please come back soon. And he came back in 2 days, and we did the biopsy. So usually we don't take a picture for the biopsy. But this case was quite interesting because when we did the punch didn't go through. It was so firm, the tissue was very fibrous, it didn't punch through, and there was very minimal bleeding. This was the whole bleeding. We expect 1 or 2 drops of blood when we do the biopsy, but there was no blood, and it clotted right away. So that's why we took the picture. And then we sent it to histopathology. Yes, thank you, Dr. Jordan. He did an amazing job. He did some 15 immunohistochemical staining, which it's very rare. I know he does it for difficult cases. This was the first picture he provided, the H&E staining. I know it's a lot of things. There is connective tissue, there is epithelium, but I've demarcated. There were some spindle cells which were stellate, rounded, and quite amorphous, not quite normal. And then he did like some immunohistochemical staining, and there were 3 main things which were positive. The first one was called as the Desmin. So Desmin is practically the one which we see in skeletal muscle. And then he did another staining called as the MyoD1, which is showing the myogenic differentiation. So Desmin was positive, showing that it is something of skeletal muscle lineage. And it showed myogenic differentiation, like not completely matured, but quite immature cells. That was 30% positive. That's the darker area of uptake, the black dots, if you see. And then the final diagnosis, it was unfortunate, and we were not actually expecting the diagnosis. It came as spindle cell rhabdomyosarcoma, which is a very rare, very aggressive tumor, not commonly present in the oral cavity, and even in the head and neck region. And it's commonly not present in adults also. It's a quite common tumor in the children, not over 45 years old. So it's coming like a short, brief history about the RMS. It's a soft tissue sarcoma, typically differentiating into the skeletal tissue. So the linchpin was Desmin positive, MyoD positive, and myogenic negative. Once we got the final diagnosis, we urgently referred him to head and neck surgery. I have to thank Dr. Ha at this point because he took the patient as early as he could, and he did the CT, PET CT, and then 13th week, an excision was done. So we always, as doctors, we dentists, we believe there should be a light at the end of the tunnel. Yes, there was a light. The excision was tumor-free. Usually, RMS has a higher potential for local and distant metastasis, but this patient, he did not have metastasis, and he was the tumors were margin-free, and he is the 3rd month follow-up, he's doing well. So to expand our knowledge, we did a literature review to see how many cases are there. So to our amazement, there were only 15 articles in the whole PubMed search giving tongue spindle RMS, and there were only 11 cases reported. And another important thing to note was there was a 3-day-old, that was the lowest age, and the highest age was actually 41-year-old. If we add this patient to the literature, he's the oldest one who got tongue spindle RMS. And another interesting finding was most of the small lesions actually were described by the dentist as fibromas or mucosal initially. And then when they did the diagnosis, it came as RMS, which is a learning point for me and everybody present in this auditorium today. And finally, there was a molecular testing done by the UCSF 500 cancer gene panel. I know this slide is a lot of thing to take, but I'll just give a summary. So there was something called as TCF12 VGLL3 fusion. So if you see in the picture, there are fusion genes which will differentiate RMS into 4 types, like alveolar, embryonal, biphenotypic, pleomorphic, and the spindle RMS. The spindle RMS has something called as the VGLL3 fusion. If you see in the third picture, this was typically present in this case. And these types are a subset which have an indolent course. It will not be very aggressive. And the predilection for the head and neck region is very common. And we see in this patient. Yeah. So yes, to conclude, what I learned from the case, I'm going to tell you all, vigilance and suspicion of all the unusual lesions. Early detection is important. Do the biopsy if there is a persistent lesion. Send a referral, follow up, monitor, take pictures. Last but not the least, patient education is very important. This patient actually sent me a lot of articles regarding RMS because we educated him and he educated us. I learned a lot from him. So that's the last point. And here are the literature review references. Here are the genetic testing and the further readings. And this was the whole literature review. If anybody is interested in the further, we can discuss. I know this is a short presentation. And thank you all for listening. And my acknowledgements for Dr. Jordan, Department of Head and Neck Surgery, my program director, Dr. Kamala Laryani, Dr. Shivvaski, Dr. Mishra, contributor, Dr. Gupta, and all the other faculty of oral medicine. Thank you.
Wonderful. We have time for one question. Have you ever had a case where you had,
yes.
Oh, there's one where you've had another sort of unsuspecting, and you picked up something that maybe you wouldn't have seen before? You say be suspicious of these?
Yeah, we do have a lot of patients actually, when like a small swelling came out to be or squamous cell carcinoma. So the thing is, if there is something persisting for a longer time, more than like 4 weeks, it's better to do a biopsy and to rule out anything. That's the takeaway point actually.
Thank you.
Thank you.
I want one last opportunity to thank all of our speakers who stayed on time with their well-rehearsed presentations. Thank you all. And that concludes our the session.
And I want to thank our session chair, Dr. Hernandez, for that excellent keeping people on time and excellent thinking on his feet for questioning some of the speakers. I want to invite the audience to scan this QR code and select one of the presentations for the so-called People's Choice. You may have seen the judges have been up since at the poster session starting very early this morning, 7:30 or 8 o'clock. And then back again, eating into their lunchtime, no pun intended. And then, so let's hear it for the judges for the time that they put in, as well as the presenters. And now you, as an audience member, get a chance to also vote. Okay, so does everyone have that? Anyone still need it on the screen? I'm going to say, think that means no. Okay, so now it's my pleasure to introduce once again our Dean, Dr. Michael Reddy.
Okay, well, it's my honor to introduce the Outstanding Clinician Award. Many of you weren't in the room 2 years ago, but Caroline actually gave the faculty research lecture 2 years ago, and I don't know how many people have done won the clinical award and the research award. She's the only one. All right, well, there you go. Congratulations. And so we've had a couple of terrific talks about oral medicine, and I want to point out that oral medicine has such a rich history at UCSF. People who are sort of legendary, Dr. Saul Silverman, was known as the pioneer of oral medicine. And his work at UCSF helped establish the protocols for diagnosing and managing oral diseases. So, when I was a dental student, I learned about these protocols in something called textbooks. This is something that you put in your backpack when you want to go rucking now and you need a little extra weight. But, really, the foundation was there. Right now, of course, you can go and visit the Saul Silverman Clinic. It's on the 7th floor of the Medical Sciences Building. Dr. Deborah Greenspan, renowned figure in oral medicine, particularly celebrated for pioneering work and understanding the oral manifestations of HIV/AIDS. She worked with her late husband, John, who was also instrumental in HIV/AIDS. But today, I have the honor of introducing Dr. Caroline Schabowski, who is a respected oral medicine specialist and researcher known for her contributions to the study of oral health epidemiology, infectious disease, and autoimmune conditions. Now, what sets Caroline apart is her ability to translate research into improved clinical outcomes. Her work in developing classification criteria for Sjogren's syndrome has been adopted internationally, enhancing diagnosis and treatment for patients worldwide. In addition to being a great clinician, she's also very talented at selecting wine, if you need a little help. And if you're a learner in the audience and thinking about specializing, I want you to consider oral medicine. Oral medicine is a fascinating specialty that bridges the gaps between dentistry and medicine and offers many rewarding aspects. You get to manage conditions beyond traditional dental problems like mucosal diseases, facial pain, and salivary gland issues. So if you're drawn to a challenging and intellectually stimulating career, we can make a significant impact on both oral and systemic health. Oral medicine can be very rewarding and fulfilling. But don't take it from me. Let's hear what it's like from one of the best. So it is my pleasure to present the Outstanding Clinician Award recipient, Dr. Caroline Schabowski.
Well, thank you so much, Mike, for a beautiful introduction. Thank you for nominating me for this award, and thank you for the selection committee. So it's quite an honor. And I'm particularly thrilled to have actually oral medicine being highlighted in this way, because oral medicine has always been a bit on the fringe. It's not quite dentistry, it's not quite medicine, it's really sort of at the interface of these two professions. And Mike mentioned Dr. Silverman. The right one, here you go. So first, before I talk about Dr. Silverman, this is the definition of oral medicine according to the American Academy of Oral Medicine. It's a specialty of dentistry that's responsible for the oral health care of medically complex patients and for the diagnosis and management of medically related disorders or conditions affecting the oral and maxillofacial regions. And actually, I like to kind of shortcut that as describing as dermatology of the mouth. And it took 75 years to actually have oral medicine recognized by the ADA. It's now the 11th dental specialty, which we're very happy about that since 2020. And Dr. Silverman was quite a pioneer in oral medicine. And he graduated from UCSF in 1954, established the oral medicine clinic that you know today, shortly after, I think around 1956. And his philosophy was that knowledge is to be tirelessly sought, freely shared, and passed on with the sole goal of advancing science to the benefit of fellow professionals, students, and patients. And all of you who've actually had the privilege of being mentored by Bud Silverman know that this is really what he believed and applied. He actually was still practicing in clinic and teaching at the age of 88, and actually had a stroke on the morning he was supposed to be in clinic, and passed about a month after having his stroke. So he really had a very long career at UCSF, about 60 years. Therefore, I was absolutely delighted in my former position as chair of the Department of Artificial Sciences. I was delighted to launch a campaign, fundraising campaign, to name the clinic after him. And we were very fortunate to have a very generous gift from an anonymous donor, $2.5 million, that established the Sol Silverman Endowment, and which will basically support oral medicine education and the oral medicine clinic sort of for perpetuity at UCSF. So this is Mike and me hosting the reception for the naming of the clinic. And here are Dr. Silverman's son and daughter. And you see Mark Kirkland in the background. And Troy Daniels, who actually was one of the first oral medicine residents of Dr. Silverman. So Dr. Silverman has mentored a whole generation of providers. So I realized that 2 years ago, I did share my baby pictures with you, but blame it on Roger. He told me you absolutely have to talk about your pathogens. So just 2 slides that are the same as my last talk. Here are my parents. I was born in Denmark from a Danish mom, Lise Palsø Andersen, and their French dad, Michel Philippot. And we lived in Denmark for a few years, where I was quite the Danish kid playing in the snow. Then we moved to France when I was around 5 years old. I quickly learned how to carry the baguette because every French kid carries a baguette. And then we moved to a town called Meudon, which is on the outskirts of Paris. It's about 10 minutes from the Eiffel Tower. And it has a 12-minute train ride. And it has this beautiful observatory that was built in, I think, 1876 after the castle of Meudon, which was built for one of Louis XIV's sons, burned down in 1870. So they didn't rebuild the castle. They built an observatory instead, which was quite a bit more practical. And they preserved the gardens, and the gardens have this beautiful view of Paris. And again, this is basically the line C of the RER. It takes you in exactly 12 minutes to the Eiffel Tower. So moving fast forward, I went to high school in Meudon, then I went to dental school in Paris. And then at the end of dental school, at the time, my father was working for an American company in Paris, and he often had American trainees. And sometimes, my parents would invite them for dinner. And so I got to meet these American trainees. And one time I told him almost as a joke, wow, you could maybe send me over there when I'm done with dental school. And so he did. And the idea for me to come and spend 3 months in the US was to basically improve my English, but also check out some of these masters that we all heard about in dental school. So in Europe, American education is very well respected. Graduate school in particular, and people who are fortunate enough to go to graduate school in the US, it's very well considered. So I did check out, came to Philadelphia. I was actually living at International House on UPenn campus, and then commuting every day to Ambler, where the company was, because at 22, you don't live in Ambler, Pennsylvania, you live in Philly. So I did check out graduate school programs, but they were way beyond my means. In France, education is actually free. So the whole thought about having to spend thousands of dollars on a graduate education was at the time unthinkable. But I did meet my future husband, Steve, on a train platform of all places. And shortly after, we actually went back to France. My parents completely understood it because they had met in the same circumstances in Paris. But my friends were horrified. You are getting married, you just met this guy, but it's been actually 39 years. So I guess we were right. So about a year after living in Paris, we moved to New Jersey. And why New Jersey? Because Steve had worked for the Department of Health in Trenton, and he could actually continue to work for the Department of Health in Trenton while getting his PhD in biostatistics, which he had deferred by 1 year. And except New Jersey was a terrible state for me. They did not recognize French degrees. So I would have had to do the whole thing over, which I just had finished a year earlier. and again, at a great expense. But there were five states in the US, with California being one of them. And by the way, Alabama and Florida, the other two, I can't remember the fourth and fifth, but California was one state where foreign trained dentists could take the bench test and then take the state board. So Steve was very happy to apply to UC Berkeley. He had lived in Berkeley in the past, loved it. And a year later, we basically moved to Berkeley, which was unbelievable. We rented this small apartment in Albany, and this is my parents visiting. And actually, I put this picture there because you notice this little workbench here. This was me practicing for the bench test. And I spent hours and hours and hours in front of that typodont. And I did beautiful gold foiled on this typodont, passed the bench test, passed the state board, and got into the AGD program. And I have to tell you, and I'm sure many of you who are foreign trained dentists can relate to that, I had actually worked for $6.50 an hour for a crown and bridge lab packing porcelain and actually having to punch a card when I went to the bathroom and thinking, oh my goodness, I'm a dentist. What am I doing here? You know, packing porcelain for minimum wages. And so by the time I actually got into the AGD program, I was like a kid in a candy store. I mean, I was so excited going to seminars, and it was actually unbelievable to me to be in this program. Now, the little secret here is that after I applied for both GPR and the AGD program, and back then we didn't have email, so I called the professors who had interviewed me to thank them for the interview, and the AGD director told me, Caroline, you know, thank you for your phone call, but I have to tell you, you're really at the bottom of our list because we just don't know about these French degrees. And we've never accepted a foreign trained dentist. So I thought, well, that's it. I'm not getting into the AGD. So when I got the letter of acceptance, I thought, oh, this is the GPR. But actually, they had merged. So all of a sudden, they accepted 10 residents. So I can really say I got into UCSF by my bootstraps. And so this was in 1989, and past the initial excitement of being at UCSF, all of a sudden I realized, wow, I haven't actually touched a patient in 3 years, except for my state board. And all the dentistry I had done over the last 3 years while we did all these moves from New Jersey to California was on typodonts. And I expected to do these exactly same perfectly square preparations on patients' mouths. And that's not exactly how it works. And I can tell you, I had zero confidence. I had lost all my confidence. It's a little bit, if you drive a stick shift and you have an accident, all of a sudden you're second guessing yourself when you're going to change gear, and you have to rebuild that confidence. And there were two people who were my heroes, Casey Nakahara and Mark Kirkland, who were both professors or both instructors in the Buchanan AGD program. And they were wonderful. They basically helped me rebuild that confidence, positive reinforcement, which actually, by the way, it's not even an expression in France. So this is a very American concept, and it's a wonderful concept. You try to build on people's strengths rather than to sap them down. And the first case, actually, this was within the first week of me starting the AGD, was the 75-year-old patient who had been sort of bounced around from resident to resident. And as you can see, was in dire need of dental care, decreased vertical dimension, just a few teeth left on the maxilla, and essentially a pretty bad situation with some partials. And so Casey Nakahara spent hours with me treatment planning this. And I learned that, oh, you can do an overdenture. So I did the root canals, the preparation. We went through this phase of immediate denture. Finally, we got to the stage of the final denture. The patient, and I wish I could actually show her eyes because she literally has sparkles in her eyes, was absolutely delighted with the final results. We're not quite done because we still had to restore her lower incisors, which we eventually did. And that is the case, my first big case in the AGD, which all of a sudden restored my confidence. And I realized, oh, I can actually do this. Now, meanwhile, we had this rotation in oral medicine. And actually, through the rotation in oral medicine, I met with Jim Winkler, who was at the time a periodontist teaching at UCSF. And so Jim was very connected with oral medicine through all his work on HIV, but he was also one of our attending in periodontics at Buchanan. And he taught us how to treat necrotizing ulcerative periodontitis, that you have to be very aggressive. You have to remove all the necrotic tissue. I still can hear Jim say, you know, it ain't going to come back to life. So basically, whatever necrotic tissue you have, you need to remove it. So we learn how to debride with povidone iodine irrigation under local anesthetic. This is the patient after the procedure going home with the prescription of chlorhexidine and metronidazole. And this is a week later. And it's actually remarkable when you can see the reepithelialization, the healthy tissue here. Now, of course, there's quite a bit of bone loss and recession, but you have to realize that a lot of these HIV patients were young men, 20s, 30s, who basically, it's a very rapidly progressive disease. So from within a month, they could basically all of a sudden have mobile teeth in their mouth and thinking they were going to lose all their teeth. And in fact, by being a bit aggressive and doing the Jim Winkler approach here, we could actually stabilize disease and salvage their teeth. And one day, this was on a Friday afternoon, this emergency showed up, and I was basically on call that afternoon. 37-year-old man presented with a chief complaint of pain, difficulty speaking and eating. He had been diagnosed with Kaposi sarcoma already and was about to start chemotherapy. But he was in so much pain and basically could barely close his mouth that he decided to come and see if we could do anything for him. So Jim Winkler was there attending on that Friday afternoon, and he instructed me to basically do that perio approach, debride, and then send him home with chlorhexidine and metronidazole, which is what I did. And this is basically a week after debridement. And it's actually, and he did have one session of chemotherapy, but it's hard to believe that with just one session of chemotherapy, you would get so much shrinkage of the lesion here. So this is an example where we got amazing results by essentially diagnosing both condition and managing the necrotizing ulcerative periodontitis, and particularly on the palatal aspect. And actually, Jim encouraged me to publish this as a case report. This is my very first publication. And if you notice the date, it was published in 1993. And I did this case probably in 1990, which means it takes you a long time to publish your first case report. So meanwhile, in oral medicine, which was a rotation, I think we spent half a day a week in oral medicine, we learned all about oral candidiasis and, pseudomembranous erythematous candidiasis, angular cheilitis, ulcers, hairoleucoplakia, different warts. And this was in Deborah Greenspan's clinic. And when I was done with my first year AGD, now that I had rebuilt my confidence, I decided to do a second year. And in the second year, you had to choose an area of emphasis. So I chose this area of emphasis as being oral medicine, and I spent now a whole day. And usually residents who did that would spend a whole day in the same clinic, but I decided to spend half a day in Deborah Greenspan's clinic and half a day in Sol Silverman's clinic. And I learned so much from them. Deborah's clinic was more focused on HIV because you have to remember in 1990, that was the peak of the epidemic. Whereas in Bud Silverman's clinic, I learned a lot about lichen planus, pemphigus, pemphigoid, cancer. But I think what I learned from these two mentors was bedside manners, how to talk to patients, how to explain disease to patients. It is so important for patients to understand what is happening in their mouths. And they were masters at this. So they were outstanding mentors. So after the AGD, I actually decided, and this was probably the HIV and sort of the curiosity in me, learning about all these oral lesions. And at the time, John and Deborah Greenspan had this oral AIDS project, a pretty large grant. And so I got interested in epidemiology, applied for an MPH. And then actually, after getting into the MPH, I was approached by Steve Silverstein, who was running this T32 dental clinical epidemiology program at UCSF, and said, well, you're going to do an MPH anyway. We have this institutional awards, a 3-year program. You do the MPH in your first year, dental public health residency your second year, and then kind of applied research in the third year. So that sounded like a great deal to me. So this is what I did. And then when I got done with the MPH, I came back and I had the opportunity to analyze some oral AIDS center data during my MPH in Epi. And then I asked John Greenspan for a job. I said, well, maybe now I can get a faculty position. And at the time, there were not that many faculty positions available. And John said, well, FTs don't grow on trees. If I were you, I would actually go back and get to your PhD. And I was actually pregnant with our first son. I thought, he's nuts, PhD, why would I want to get a PhD now? And then he said, well, but what you can do is actually, there is this Dentist Scientist Award, individual K-15 that you can apply for. And again, before the internet. So I called the NIDCR, got my little brown envelope, filled out the application, basically wrote a grant proposal. And of course, John was the ultimate mentor, gave me access to his sort of pre-award administrators who helped me draft the budget, because I had never obviously written a budget. I did not get it the first time around, but I got it the second time around. And Bill Bird at the time, who was involved with the dental public health residency and that program, allowed me on my third year of the dental clinical epidemiology program to actually take all my PhD classes, which was fabulous. And then I started the oral medicine residency around 95 and ended that in 1998. So I ended up doing my oral medicine residency. That was the whole point of the Dentist Scientist Award. You had to choose a PhD and a specialty in clinical dentistry. And obviously oral medicine was very suitable with epidemiology, and it's been a great combination. So I'm going to go through a couple of clinical cases. We've been very fortunate to have two fantastic presentations by some of our oral medicine residents. So you get the drift of how these cases work. And so I'm just going to go and present a couple of cases. And I extracted those from, I actually was invited to present grand rounds when I was in sabbatical and spent some time in the rheumatology unit of one of my colleagues in Paris. And so, and I picked those cases because they're probably, they illustrate the interface between dentistry and medicine quite well. So the first case is a 51-year-old man who's referred by a periodontist for evaluation of severe gingival swelling of his posterior quadrant, doesn't have any pain except he has a bad taste sensation. And he tells us that this actually has started 5 weeks earlier. Now, what I should mention that I saw this case probably maybe it was a couple of years after I had graduated from oral medicine, and Deborah Greenspan went on sabbatical and asked me to look after her clinic. So all of a sudden, I was on my own in her clinic, basically as a very junior faculty. And this is a case I saw at that time. So it was actually amazing to have Bud Silverman's office just down the hall, and be able to go and knock on his door whenever there was a question or I wasn't quite sure. So again, this patient reported rapid progression, and some of his posterior teeth were presently covered by the overgrown tissue. And he said otherwise he felt quite well, had no systemic sign or symptoms. He actually bragged about not having seen a physician in 10 years, saying he was in really good health. He didn't need to see a physician, but he was getting regular dental care, and he was not a smoker and reported social drinking. So this is what the lesion looked like. And you could see it's pretty alarming here. This, And we call that sort of strawberry gums, very overgrown, very friable, kind of hemorrhagic type tissue. And he had it mainly on his upper right quadrant, but also on the palatal aspect. So the differential diagnosis for this, the first we thought of was an autoimmune process. So, and the one that came to mind, which at the time was called Wegener's granulomatosis, now it's been retermed granulomatosis with polyangiitis, GPA, which is a type of vasculitis. And vasculitis is essentially inflammation of blood vessels. And the strawberry gum is one of the sort of very characteristic signs of GPA. But could it be an infectious process? Could it be, for example, bacillary angiomatosis or a deep fungal infection? Or could it be actually a blood description, particularly a neoplastic process? So we obviously thought of leukemia. Now, the differential Wegener's or GPA was high enough on the differential that I went ahead and collected a biopsy on that first session. And we went ahead and ordered some blood work, and the biopsy was nonspecific. And so it was just basically a bunch of granulation tissue. What the pathologist expected to see here, and at the time this was Joe Rigezzi, who was still with us at UCSF, what he expected to see if it was GPA would be granulomatous inflammation. But in that first biopsy, there was none. And meanwhile, 1 week follow-up, all blood work comes back normal. We couldn't quite rule out the bacillary angiomatosis with special stains. So we decided to put him on an antibiotic just in case he had an infectious process. At 2 weeks follow-up, absolutely no response to antibacterial therapy. The condition is rapidly progressing, as you can see. Now, basically, it's affecting pretty much all his quadrants. And he's a lot less cheerful than at his first visit, is reporting discomfort, difficulty eating. He's had some weight loss, fatigue. And I reach out to dermatology where I get advised to order ANCA titers, which are very specific for GPA or for vasculitis in general. And you can't always believe the first biopsy. So essentially, even if your first biopsy is nonspecific, you have to kind of keep going. So obviously, we went ahead, and this is at 3 weeks follow-up. So you can see that at this point, almost his entire teeth are covered. So I collected a new biopsy, ordered the ANCA titers, and this time the pathologist did find granulomatous vasculitis and signs that were very specific for GPA. So GPA was confirmed based on the elevated ANCA titers, the C-ANCA titers, the biopsy results. He was actually admitted to the hospital with, by then, severe dehydration, weight loss, anemia. They did a chest X-ray because that's where GPA is often manifest. It will attack the lungs and often the kidneys. Rheumatology assumed the care of the patient. He was put on cyclophosphamide, which back then, this was about 20 years ago, a little more, cyclophosphamide was kind of the standard of care for GPA, and high-dose prednisone. And this is 2 weeks after initiation of that treatment, which is mind-boggling. How can the body reabsorb all this excess tissue? So this was truly unbelievable. And this is actually just 4 weeks following treatment initiation. So we felt so elated. I mean, we thought, wow, this is amazing. You know, he was diagnosed through oral medicine. You know, this is amazing. Basically, now he's on his merry way. Except 7 weeks after treatment initiation, he started complaining about severe lower extremity muscle pain and joint pain. And rheumatology actually suggested that they increase the cyclophosphamide, they want to double the dose. And unfortunately, by then, actually, internet was around, and the patient had read that cyclophosphamide can have a lot of side effects. And he was convinced that his myalgia and arthralgia were due to the cyclophosphamide. So the patient declined to take a higher dose of cyclophosphamide. And to this day, I wonder if he actually even cut back his dose of cyclophosphamide himself, and we'll never know. But 2 months after treatment initiation, he was readmitted to the hospital. He had severe pain, anemia, elevated liver enzymes. Basically, he had infarctions. Essentially, when the blood can't circulate in certain organs, you can get infarcts, and so he had an infarct in his spleen. He had some heart damage. He was placed on morphine because of the severe myalgia. He developed skin lesions, these purplish skin papules on his face and on his hand. And he developed a low-grade fever, fatigue, nausea, sweating. The chest radiograph revealed like pleural effusion. He was placed on furosemide and digoxin. He basically had arterial occlusion in his heart, secondary to the vasculitis. They did try a balloon angioplasty, which was unsuccessful. They finally attempted what they call pulse cyclophosphamide, very high dose IV, to try to control the generalized vasculitis. But within 10 days, he developed severe abdominal pain, chills, bright red blood, perectum, and they tried a laparoscopy to see where the bleeding was coming from, but unfortunately, he died shortly after in the ICU. So this is a sad case and a disappointing case, because we initially were so happy that his oral lesions were actually responding, which were quite dramatic, were responding to the systemic treatment. But in fact, the final outcome, there was an autopsy that was performed, and the pathologist, who was Henry Sanchez, who's still here at UCSF, and I remember actually meeting him in the hallway after he was done with the autopsy, and he said, I don't think this was GPA. This guy had thrombi all over his body, in the heart, the kidneys, the spleen, the prostate, the testicles. And so he had multiple infarctions all over his body. The kidneys show glomerulonephritis, and he found no necrotizing granulomatous lesions on the autopsy. So in the end, he actually diagnosed it. The final diagnosis ended up being what's called microscopic polyangiitis, or MPA, which it's related to GPA, but it affects smaller blood vessels, and it's probably overall a more severe disease than GPA. GPA is serious as it is, but MPA is probably worse. So this is a very unusual case of MPA with oral manifestations as the first clinical signs, which had actually not been seen before. And it presented with this granulomatous vasculitis, elevated C ANCA, so that's why we initially thought it was GPA. And the striking resolution of the hypoplastic tissue in the mouse within a month suggested that GPA was responding to treatment. And it demonstrates that, in fact, MPA can still be active and involve multiple systems despite resolution of oral lesions. And we actually published this case because it's important to share those kind of cases with the broader community. And today, by the way, both MPA and GPA would be managed with rituximab, which is a biologic agent, and which would be a lot more effective and probably more predictable than cyclophosphamide. So the second case, this is a 61-year-old woman who's referred to us, actually to me. She was supposed to come to my clinic on a Monday, and then the nurse who was working in the transplant unit called me on Friday afternoon and said, "Can you see her? She's in terrible pain." And so the patient came into the clinic, and she was describing basically these non-healing gingival ulcerations, and said it feels like deep bone pain. And she had this foul taste in her mouth. She had had this for 4 to 6 weeks, but in the past week, the pain had gotten much worse. And she first noticed this after a dental cleaning. She had received Valsite for management of a cytomegalovirus infection 3 months earlier, and was given another course of Valsite just in case this was again CMV, but did not respond to it. So she was one of the first recipient of a pancreatic islet cell transplant 5 years prior, as management of type 1 diabetes. And she had hypertension. The current meds included Myfortic, which is sort of an anti-rejection drug. It's an immunosuppressant, and then blood pressure medications. She had a history of aspergillosis 1 year prior, and a history of CMV 2 months prior. And this is how she presented. And I'm putting sort of the date because it's you'll see why I'm mentioning the actual timetable. So this actually looked a lot like ANUG or necrotizing ulcerative periodontitis. And this was her main source of discomfort here. So our differential included ANUG and necrotizing ulcerative periodontitis, as well as potentially a deep fungal infection. You always suspect deep fungal infections in immunosuppressed patients whenever they have those kind of lesions, or potentially a lymphoma. So lymphoma is about 35 times more likely to occur in patients who've received either solid organ transplants or bone marrow transplants. So this was on a differential. So the plan was to actually collect the biopsy ultimately, but this was Friday afternoon, 4:45. And also we did want to sort of give it a chance. If this by any chance was ANUG or NUP, it would respond to metronidazole. So she went home for the weekend with the metronidazole and chlorhexidine, and we would see her 3 days later for the biopsy unless the lesion substantially responded to treatment. And this is when she came back the following Monday, so 3 days later. And you can see that there's not much improvement here. And now all of a sudden, she actually has another lesion here. So we went ahead and did biopsy. So I collected a punch biopsy from the lower. I suspected this was different from this, actually. So I collected a specimen from the lower lesion and just sacrificed this papilla here on the upper. And this was exactly 7 days later. So by then, having been on metronidazole and chlorhexidine for 7 days, you could see that this actually had quite improved. But then she had these other lesions developing. And on her maxilla, she had all these new areas here on the palatal and on the buccal, just 1 week later. And the final biopsy was actually signed out. The lower anterior area was basically this acute and chronic mucositis, which was consistent with ANUG or ANUP. But the gingival lesion was consistent with basically a B cell lymphoma. And she had, the pathologist did in situ hybridization that revealed Epstein-Barr virus was involved with this. She had a PET scan that showed that not only her gums, but her tonsils were involved, and she had some pulmonary spots. And then the treatment plan included tapering the Myfortic and a 4-week course of Rituxan, and 3 months after she was completely disease-free. So this was an interesting case from the standpoint of the very rapid onset of the lymphoma. So as oral medicine providers, we see dramatic cases like this, but then we also see things that are much less mundane. And burning mouth syndrome is one of these things. So what is burning mouth syndrome? It's basically defined as a benign condition that presents as burning in the mouth in the absence, that at least 2 to 3 months duration, in the absence of any clinical signs and the absence of any abnormal blood tests. It affects predominantly postmenopausal women and has been linked with anxiety. And it's often exacerbated by salivary hyperfunction, which may also be a consequence of anxiety. And the reason why I mentioned burning mouth syndrome is because these patients come to us and they've seen, 3, 4 providers who basically keep telling them, I don't see anything. There's nothing wrong with your mouth. And it's probably all in your head, probably psychosomatic. And these patients are desperate. It burns. Usually it's on the tongue, sometimes in the palate. The level of pain varies, but you can't just ignore it. Essentially, and that's where the teachings of Silverman and Greenspan were so important. You have to learn how to explain to these patients what is happening. So we often explain it as this hyperstimulation of nerve endings, which essentially is sending this message to their brain and is manifesting as burning. Often by learning what they don't have, tell them they don't have an infection, they don't have cancer, they don't have actually anything that's going to be life-threatening at some point, but indulge them with their diagnosis. Do tell them that, yes, there is something going on. Very often, actually telling them what they don't have is enough for them to say, well, I can live with that. Sometimes we have to use gabapentin. In the old days, actually, I remember Dr. Silverman would often prescribe Librium and clonazepam, which it responds very well to that because it is linked to anxiety. But this was before the time where we knew how addictive benzodiazepines were. And so we honestly no longer use this today because we've learned a lot about benzodiazepines, but gabapentin is a drug that works quite well for that. And somatic symptom disorder is probably a bit related to burning mouth syndrome. And it's another one of these things people don't always report burning. So this is an example of a patient we actually saw quite recently, saw several of us actually in the clinic, 63-year-old man, very articulate, very educated, who presents to clinic reporting that he has these particles emanating from his lower gingiva. And there's no pain. He reports it's been there for 4 years. It was initially affecting a large area in his mouth. It responded to a deep cleaning by a periodontist, although the symptoms have returned. And he's seen multiple providers, had tests for bacterial, fungal infection, all negative. And he feels that he's been ridiculed. That's a word he used actually by his PCP and by all the other providers. Say, well, the periodontist stood 7 feet away from me telling me you don't have any, I don't see any particles in your mouth. And he is convinced that he has these particles in his mouth. And it's, almost a bit, you can sort of almost laugh about it, say, well, then he's head and basically needs to forget about it. But you're the 5th provider he's seen. So we need to do something. And that's where empathy and active listening are extremely important. So you can't just dismiss it. He feels he's got particles. So you can actually try to explain it from the physiology of it. Like, well, our epithelium sheds dead cells every day. The tongue has exquisite proprioception. And some patients may have really exacerbated proprioception. So in your case, it might be that you're just sensing, normal epithelial shedding in your mouth as these particles. And the reason I mentioned this case is because very often this ends up being referred to cognitive behavioral therapy. They need to be treated but it's very difficult as a dentist or even oral medicine provider to all of a sudden send somebody to psychiatry for cognitive behavioral therapy. So you have to basically be able to introduce this very, very carefully. So the conclusion of it, and the reason I mentioned these sort of 2 conditions after the 2 dramatic cases is because it's not only important to in oral medicine to take thorough to take thorough histories, to be in very close communication and interaction with generalists and specialists, both in dentistry and medicine, but active listening and empathy are extremely important. UCSF has a long history of pioneers and role models in the field of oral medicine. And I think that the UCSF pride values are actually particularly relevant to the practice of oral medicine, except I would actually add an E to it for empathy. The diversity part, I think it's interesting that if you look at oral medicine at UCSF, it's had actually astounding geographic diversity. So we had Dr. Francina Lozada Noor from Venezuela, Dr. Greenspan from the UK. We have Dr. Velupillay from Sri Lanka and Sweden. We had Dr. Alessandro Villa from Italy, Dr. Kamal Alaroyani, who joined us a couple of years ago, is our new program director and clinic director from Yemen. From France, we have Dr. Mishra from India. And it's extraordinary how much diversity we have in our clinic. So this particular award is a great tribute to oral medicine, but it's also a great tribute to foreign trained dentists and to all of us who basically are immigrants, because we are part of the fabric of this country. And I think it's particularly relevant today to actually pay tribute to us. So just the key elements which were critical to my career as a clinician scientist. I've had outstanding mentorship and role modeling. I think I've been very curious and I believe in lifelong learning. I've had an outstanding community of colleagues, and I've already listed many of them. And I shouldn't forget Richard Jordan, who, by the way, is from Canada. And Richard Jordan is a fabulous, he probably is one of the best orthopathologists in the country. I basically have his cell phone number on speed dial on my cell phone because it's lifelong learning. Whenever there's something we basically don't come across in clinic that we haven't seen before, its consultation is really important. Now, of course, life-work balance is incredibly important. I've been very fortunate to have outstanding support from my life partner. And if you choose to have children and you choose to have a family, that's where life-work balance really matters, and strong support from your partner really matters. So I think we've achieved as women equal rights and equal pay, especially at UCSF, but we also need to have equal labor distribution at home. And so it's been really, really important. This was Eric, who was born in 1993, and our son Hugo was born in 1995. And Eric was born during my dental public health residency and 9 months before starting my PhD. And Hugo was born actually 9 months after my qualifying exam. And so you can imagine that, it was very important to have a supportive partner. Our boys have been very fortunate to grow up in a bicultural environment. We went to France every summer. We were hiking in the Alps, and then little boys become grown men. And this is actually awesome grown men. I have to say they're just as awesome as their father. And this was in Copenhagen and Tivoli. I was delighted to be able to share that with them. Last summer, we went on a family vacation. And this is in the Lofoten Island hiking, where it's actually light 24-hour day. And both our sons are musicians. They studied jazz composition at UCLA and got a BS in cognitive science. And they're doing the very brave choice of being artists and musicians. They actually are supporting themselves from their art. So I'll be happy to take any questions. Yes.
I have a question about tic douloureux, which as a pediatric dentist, I know it was an enigma in terms of not what it is, but how to treat it, not just to alleviate pain. Any news or update on how to treat and finally, get rid of tic douloureux, or is it something that patients just have to live with?
So tic douloureux is trigeminal neuralgia, and we have Dr. Alariani sitting right here, who's actually dual certified in orofacial pain and oral medicine. And so I'm actually going to pass the question to him. Oh, you can talk to him afterwards. And actually, it's been honestly a godsend to have him join our clinic, because oral medicine is supposed to actually encompass, we treat burning mouth syndrome, but we're not, obviously we're not orofacial pain specialists. And orofacial pain is a very common condition. And I think it's maybe even more common now because people are more stressed out. It's very associated with anxiety. So it's been wonderful to have Dr. Alariani with us. And please do talk to him afterwards. All right, so I guess it's picture time.
Which is your better side? Congratulations. Lovely job.
Great. All right. Oh, this is beautiful.
I guess you.
You know how to get the slides to show? Do I need to? Oh, there we go. All right. So now we're going to move on to present the Mentor of the Year Award. I want to first thank everyone for joining us today as we come together to celebrate the incredible individuals who have made a difference in our research community. Obviously, all of the fellows who have conducted research and also the postgraduate students and everyone who is involved in RCED this year. Today, JGS has the pleasure of presenting one individual who best exemplifies the qualities of a mentor. Someone who has guided, inspired, and shaped the lives of those around them in meaningful ways. Our mentor this year was chosen because of her ability to foster an inclusive, nurturing environment. Students have said that she encourages them to think beyond the boundaries of their specific disciplines and has helped them understand how their diverse experiences can help them grow academically and also professionally. Outside of being an amazing scientist, she has also gone out of her way to nurture her students, meeting with them, listening to their concerns, and inspiring them to be the best person they can be. Please join me in congratulating Dr. Kristen Kearns.
I didn't.
Oh,
They didn't warn me.
It's just a couple
Oh,
words.
okay. Roger, you said I didn't have to say anything. That's not fine. Well, of course, this is just wonderful. Ton, thank you so much for the nomination. This is one of the best parts of my job. Really, it is. Had a lot of mentors in my life, as we all have, whether they've been professional or personal. Sometimes those relationships can be challenging as well, and we often learn our best lessons from some of those relationships. I take mentoring very seriously. I feel like everyone that's been a mentor in any way, shape, or form, including many people here, Stuart, Lisa, Beth, Ben, I take pieces from all of you and try to weave those together into being the mentor that I really hope that I can be. So thanks, Ton, and thanks to all of you. I really appreciate it.
You guys can yes.
Oh, what are you?
Just hold it with them.
Oh, okay. There's a raffle. Is everyone aware of the raffle? I didn't get a ticket, so.
In a shoebox, very unusual.
Okay.
2 winners.
Okay. There's 2 winners. Are you ready? Are you ready for your long speech? It's going to be a 50-minute speech.
Yes, hang on. What?
He's got a ticket.
Wait, you have a ticket?
Bring your ticket.
You have both sides of a ticket? Okay. Okay. Ready? Use the way. Listen up, guys.
Okay, so ready? 3, 6, 3, 5, 6, 9.
Yes.
Oh, we have a winner.
We'll be in touch.
Just give me your ticket, and I'll not give you the thing that you're going to get. So brilliant, number one, and we have a second.
Yep, one more.
One more. Okay.
There's no prize right now, Sean.
Yeah.
But you can come down.
Okay.
You.
Okay, you ready? 3, 6, 3, 5, 7, 1. Oh, how did you? What is going on?
It's a D1 conspiracy.
Anyway, I thought it was a bit funny because it's like 3 different. Anyway, okay, great. Thank you. So good. We can't give you anything right now because we would have gone by it.
We don't know. We'll have something for you both. Great, I'll take care of that.
Okay.
Now it's Stuart and the awards.
Stuart.
Come on. So we need to ask everyone who comes up to accept this award with the symbolic scroll.
We're still
to
doing
step
that.
aside and be with Joey. Could you just go back to where you were? And we're gonna send all the awardees to you. Right.
Okay, first I want to take this opportunity, because he's here, to thank Roger and all of the staff who have helped make this event. He doesn't like these sorts of things, but he is here right now, and we're very grateful for all of his work. So thank you. All right, so first, this is an honor and a pleasure for me to have this opportunity to give these awards out. It has been a tremendous day of presentations, of wonderful science, sharing clinical cases, showing the interactions between the research and the clinical case and back again. It's really been a wonderful day. I don't know how the judges made their decisions because they were all great presentations. There are different categories. So I will start with the Research Associate category. There is one award, and that is going to Kevin Liu with the mentor of Dr. Hoblitz. If you are here, please come down, and you get to pose with the ceremonial scroll that will then be recycled for the next winner. Over this way. I meant to do
Yes.
work with. And that way. Oh, yes. And please, all the awardees, wait for one large picture at the end. In the resident category, we're going to start with third place, Dr. Michael Lodolo. Yeah, there's always one. Second place, Dr. Miranda Yip. And first place in the resident category goes to Dr. Catherine Sid. And I hope I said your name right. In the postdoctoral category, The third place award goes to Dr. Nathan Griffin.
Thank you.
Its second place award goes to Dr. Chan Hee Monk. And first place goes to Dr. Arvind Arul Nambi Rajan. Okay, in the graduate category, third place goes to Tony Chu, with the mentor of Dr. Saleri. Second place goes to Amira Hack, the mentor of Dr. Klein. And in the graduate category, first place goes to Min Young Kim, with a mentor of Dr. Hutchins. Okay, so now for pre-docs. The People's Choice Award. The People's Choice Award goes to Tony Chu. And for the pre-doctoral category, third place to Jothan Saddam, the mentor of Dr. Bush. Second place to Annie Yang, the mentor of Dr. Starr. And in the pre-doctoral category, the first place award is known as the Ernest Newbern Award for Research Excellence, named after our former faculty member who founded the pre-doctoral research program and ran that as an NIH-funded grant for many, many years. And the first place award goes to Paulo Orobia, mentor Dr. Hoblitz. And those are the awards for today. Everyone, I hope, was rewarded by being here today and learned something new. Again, I want to thank everyone, and I will hand it back over to Dr. Knox to wrap things up. Thank you.
Such a fantastic day. I hope you enjoyed it as well. I know that all the faculty members have lots of smiles and sparkles in their eyes, and I can see that in many faces here as well. There's a lot of people to thank. Our plenary speaker, Professor Agalu, amazing. Clinical Spotlight, Jean Starr, where is she? There she is. There she is. We have an outstanding clinician, Caroline Sabowski. We have a fantastic dean who basically helps put this thing together, Dr. Reddy. Stuart Gansky, of course, you just had to hear him all day as well. The Research and Clinical Excellence Day Planning Committee, if you would like to be part of that, and talk to us about, what we can do even better. Although I thought this was a brilliant, maybe one of the best of all time. So you're going to have to figure something out there. The session chairs, Drs. Kulkarni and Hernandez, all the judges, thank you so much. Poster judges, you're amazing. It put a lot of effort into this. I hope every poster person appreciates that effort. The John C. Green Society, Jess Cook and Eric Yin, all of our staff and our student volunteers today. Thank you for putting your hand up and getting in there and doing this. We can't do it without you. The AV support. Yes, that's you, John Tess. Thank you so much. And of course, Roger. And Mary Pope Fitzsimmons as well. Thank you guys so much. And thank you. Thank you for being here today. I know some of you feel that, how could you not be here? I know I feel like I cannot be here because it's so fantastic to see such dynamic talks. Now, I feel embarrassed because your talks were so good. I don't know if I could ever live up to that, but I'll do my best. So thank you. I'd love the encouragement. Thank you so much for attending. Let's do a big round of applause for you, for everybody today.